Hi everyone, this is Jenna Kelly. I am covering the topic of ICU prophylaxis with Jerica Singleton. We both acted under the mentorship of Dr. Dell. I will be covering the topic of stress ulcer prophylaxis, and so here I've listed some of our objectives. We have, first of all, that we want you to understand the complexity of stress ulcers and appreciate the importance of prophylaxis, especially in the ICU population. We also want you to be able to comprehend the controversy that exists among the various treatment approaches for stress ulcer prophylaxis. This is specifically talking about the conflict right now between histamine receptor blockers and proton pump inhibitors. The next objective is for you to be able to choose an appropriate prophylactic regimen for a given patient case, and we want you to be able to defend that agent of your choice. We also want you to be able to advocate for your patients by critically evaluating the need for stress ulcer prophylaxis. So when they're discharged from the ICU, they should no longer be on the prophylaxis. So we want you to understand your role as a pharmacist and how you can intervene in making sure that they're not taking any unnecessary medications when they leave the ICU floor. So at this point, I just wanted to go over some of the videos that I asked you to watch in your pre-class assignment. From the videos, what I most wanted you to get out of it is that a stress ulcer is defined as a type of erosive gastritis that occurs in critically ill patients with severe physiological stress. Now, some of those stresses can be surgery, trauma, organ failure, sepsis, severe burns, or neurological injuries. And once these lesions do develop, they vary in severity. So you can have just initial lesions, which is typically what we see within the first 24 hours of ICU admission. This will look like subepithelial petechiae. They're like little red spots. They're typically asymptomatic and you wouldn't have perforation of the gastric mucosa. But again, this is the early phase of the lesion. The next category of severity are the superficial erosions. Now these involve the capillaries, so it's getting a little bit deeper. And then finally we get to the actual ulceration where we do have a perforation in the mucosa, and this is typically where we will actually see the bleeds, which are associated with the significant morbidity in the ICU. This picture is just here for you to be able to appreciate the severity of what can happen if we do not prophylax against a GI bleed. So what can start off as a simple, subepithelial petechiae, as I said with the initial lesions in the last slide, can soon develop into an ulcer which actually has perforated the lining of the stomach, and that's when we have GI bleeds, and you can see that this would be certainly a problem for our patients. So just a little bit more background information about ulcers that you might not have gotten out of the videos that you watched. I just wanted you to know that they're usually going to occur within the gastric fundus, which is a section of the anatomy of the stomach, but they can also involve the antrum or the duodenum. And the ones that do involve the antrum or duodenum are typically appearing later in the hospitalization. These are the ones that are deeper and greater likelihood of developing into a bleed. So those are the more dangerous ones as opposed to the ones that we'll see in the gastric fundus. But all of them we certainly want to avoid for these patients because they will definitely be uncomfortable. The GI bleeds, they are not always considered clinically significant. Now, of course, we don't want a bleed in any of our patients, but they would not be considered clinically significant bleeds or life-threatening bleeds until they become overt bleeding with hemodynamic changes. And these hemodynamic changes can include anything from tachycardia, hypotension, orthostatic changes, or decreases in hemoglobin concentrations by more than 2 grams per deciliter. I think it's really important at this point for you guys to understand this definition of clinically significant bleeding because that's something that comes up a lot in the primary literature. When I go through the studies later, I will talk about how they might have seen differences in bleeding, but not necessarily differences in clinically significant bleeding. So I just wanted to give you that background at this point so that you can understand when I do talk about it in the studies later. So now that I feel like I've convinced you pretty well that this is a problem for ICU patients, I did want to discuss how often it happens and how likely it is that our ICU patients will develop a clinically significant bleed as a result of a stress ulcer. So to begin, more than 75% of all ICU patients will develop mucosal lesions that are consistent with stress-related bleeds within the first 24 hours of admission. Again, these are those initial lesions that are not super severe at the beginning, but up to 25% of those will develop into an overt bleed, and of that, 6% of them will develop a clinically significant bleed. Remember that definition from the previous slides. And these significant bleeds will lead to an increased length of stay by upwards of 11 days in the hospital. This slide should look pretty familiar to all of us. It's nothing that's new at this point. It's just the basic mechanism by which a stress ulcer can develop. You'll notice the big yellow outlines that I have on this slide are surrounding the proton pump, which is where one of our major classes of medications will work to decrease the acidity of the stomach. And I've also, on the other side of the parietal cell, I've circled the H2 receptor, which is another location of the medications. It's a target receptor of the class of H2 blockers. And so what I wanted you to understand from this slide is the basic pathophysiology about how ulcers happen. And typically they happen by an increase in the secretion of pepsin and gastric acid, and this disrupts the normal homeostasis that occurs between the gastric mucosa and the typically acidic environment within the stomach. So basically what you got here is you got your stomach lining, and it's always coated with this thick mucus layer that acts as a barrier to protect it against the acid that is necessary to not only to digest our food, but also to prevent any unwanted bacterial invasion. Basically, it kills off any bacteria that doesn't belong. So it's a protective mechanism that we have. This can also be caused by disturbances in GI motility. So if your stomach isn't moving things along, you may have a buildup of acid, and that may erode away again at that mucosal layer. This can also occur when you have decreased blood flow to the GI, which should sound familiar as something that can tend to occur in our critically ill patients. So I just wanted you to understand how it happens and why the medications that we have are the ones that we use for stress ulcer prophylaxis. I alluded to this a little bit in the previous slide. The significance of this chart here is for you to be able to understand how critically ill patients are at a higher risk of getting a stress ulcer and then would therefore be the ones who require stress ulcer prophylaxis. Because you might think, anybody who's stressed might need to be on one of these agents to prophylax against a stress ulcer, but why specifically patients in the ICU? And so I wanted to put this, I think it's a really good graphic representation of how when you're in the ICU, you tend to have an increased release of catecholamines, which can lead to vasoconstriction, and if you have that vasoconstriction, you're not getting as good of blood flow to your stomach. You're also having decreased cardiac output, which again will cause a decrease in the perfusion to your stomach. If you're hypovolemic, same scenario, and if you're releasing the pro-inflammatory cytokines, which we do see in our critically ill patients, again, we're reducing blood flow to the stomach. So this specific slide will definitely show the pathway by which decreased blood flow is what is the ultimate underlying cause of why the critically ill patient population is the one at especially high risk for developing an ulcer. And because they have decreased blood flow to their stomach, they don't have as much of the base, the bicarb in their system, so they're not able to counteract the acidity in their stomach. So we've got reduced bicarb, reduced mucosal blood flow, decreased GI motility, as I spoke about before, and also what's called acid back to. So all of these things can contribute to what an acute stress ulcer can develop in the ICU patient. So what specific risk factors for ICU patients warrant the need for pharmacologic intervention for the prophylaxis against stress ulcers? This table here, Table 1 from uspharmacist.com, it talks about the two categories of risk factors. You've got either very high risk or just regular high risk. And these risk factors are what indicate whether or not a patient would certainly need stress ulcer prophylaxis. So what I've seen in the studies is that if you're one of these very high risk patients, if you have prolonged mechanical ventilation for more than 48 hours, or if you have coagulopathy, either one of these scenarios by themselves is enough for you to definitely need something for stress ulcer prophylaxis. The other agents, sepsis, renal failure, hepatic failure, hypotension, trauma, major surgery, severe burns, anticoagulation, severe head or spinal cord injury, a myocardial infarction, neurological surgery, multiple organ failure, ileus, high-dose corticosteroids, history of GI bleeding, or low intragastric pH. Any of these situations would certainly indicate that a patient would need stress ulcer prophylaxis. So sometimes they'll say that you need one independent risk factor, which would be your very high risk factors listed in this chart, or two of the other risk factors. But typically what you'll see is that anybody with any risk factors basically is getting on one of these agents. And in fact, a lot of the issues that you'll see when reading the literature is that we are overusing these agents unnecessarily. And so that's something to definitely think about is, maybe we need to dig a little bit deeper and figure out exactly which patients actually need it so that we're not overusing the medications, because as I'll speak about later, these medications certainly have their list of side effects. Before getting into the really big controversy of the subject of stress ulcer prophylaxis, which involves the H2RAs and the PPIs, I also wanted to just give you a little bit of information about antacids and sucralfate, which were other agents that had historically been used for the same indication. The antacids, as we know, they directly neutralize stomach pH, but the problem with them is that they act so quickly and they act for such a short period of time that it's too frequent of dosing for us to realistically use these in the ICU. The nurses would just be in the room all the time. They also would have to go PO, so what happens if we have a patient who's NPO? Now this option goes out the window. Also, these medications increase the risk for aspiration pneumonia and toxicity, especially seen in patients with renal issues, which again, we're talking about ICU patients here, so this is not an uncommon thing to see. Also for sucralfate, this medication works by forming a protective barrier by adhering to the epithelial cells of the stomach. It does not act on the acidity of the stomach. So it's not really changing the stomach pH in any way, it's just forming that protective barrier. It's really sticky and disgusting, so it includes NG tubes, which again are very common in the ICU. It can also lead to constipation, changes in electrolytes, and there's tons of drug-drug interactions. And these patients are on several medications, so avoiding drug-drug interactions would be preferable. So really what the bulk of our conversation here on this presentation is going to be about will be our H2RAs and our PPIs. Again, as I said before, these are the two classes that we'll be focusing on, are the histamine 2 receptor antagonists and the proton pump inhibitors. Both of these agents, through different mechanisms, act to inhibit gastric acid secretion. So for the rest of our lecture, we'll be talking about those two agents specifically. Before really getting into the depth of the lecture, I want to first form this background. Whenever I'm talking about any of the agents, I want you all to consider three specific things: the cost of the medication, the route of administration, does it come available IV and PO, and especially because we need to understand the importance of having both options available to us in this population, and also the adverse effect profile of this medication. Remember that we're using this for prophylaxis. This is not an issue that the patient currently has that we're treating for. So a person who comes in with, obviously they have something wrong with them because they're in the ICU, but they don't have an ulcer. And now we're giving them a medication because maybe they're going to get it. We don't want them leaving with something worse. So think about the adverse effect profile and really think about the risks and benefits of adding this agent onto their profile. So first, let's talk about the H2RAs. The H2RAs are the most widely used class for this indication for stress ulcer prophylaxis. The data is certain about their superiority when compared to the placebo, also to antacids and sucralfate, which, as I said, were historically used, but not so much anymore. The mechanism for these, they act by competitive inhibition of the H2 receptors on the parietal cells, as you saw in the figure on one of the previous slides. And through this mechanism, they act to decrease acid secretion in the stomach. They can have either intermittent dosing or continuous infusion. Which one is better? The jury's still out on that. But one thing about these agents to keep in mind is that patients can develop a tolerance to them within 72 hours. So even though they might work for the first 72 hours, that effectiveness could start to subside after that 72-hour mark. So that's important to keep in mind for somebody, who will potentially be staying in the ICU for a longer duration. Also, these medications are renally eliminated, so they'll require dose adjustments. Examples of these agents include cimetidine, or Tagamet, ranitidine or Zantac, and famotidine or Pepcid. They're all available both oral and IV, which is great. IV cimetidine infusion is the only agent that actually has an FDA approval for prevention of bleeding in the critically ill, which is quite interesting because it's probably the one that I have seen the least. Continuing on with our H2RA discussion, as I alluded to before, we're not really sure if intermittent dosing versus continuous infusion is better, and we're not really sure if IV versus PO is better. But we do understand that an oral medication, any oral medication in the critically ill population could have erratic absorption, and so that could be an issue. There's also significant data that establishes their efficacy, but this is largely based on the comparisons to the older agents, the antacids, sucralfate, or again to placebo. So this is not comparing it to PPIs, which weren't out on the market until much later. Also, the costs associated with these agents. I found a study that said that it was like between $6,655 up to $7,986 spent on this medication before you're preventing one episode of upper GI bleeding. This was also from the 1999 ASHP guidelines, so, just think of inflation. Also, as far as adverse effects associated with these medications, nosocomial pneumonia is the biggest one. There's also drug-drug interactions, mostly seen with cimetidine, which is probably why it's used the least nowadays. And also, they work through the P450 inhibition, so you can see how many drug interactions are possible here. Also, thrombocytopenia and the renal dosing is sort of a little bit of a drawback. But once again, IV versus PO, we have both options available, so that's really good to have. Now we'll switch gears and I'll introduce you to the PPs, the proton pump inhibitors. They have little evidence so far of clinical superiority over H2RAs. You'll hear some people say that that's because they're just newer on the market, and once the evidence is there, it will be, a slam dunk that definitely PPIs are better, but we'll see. The mechanism of action for this class of medications is that they work through inhibiting the ATPase pump, the proton pump, and this decreases the stomach acidity. So they have established profound efficacy, and they don't show that same tolerance development like what the H2RAs have within the first 72 hours. So that's cool. Some examples of these agents, we have omeprazole or Prilosec, pantoprazole or Protonix, esomeprazole or Nexium, lansoprazole, Prevacid, or rabiprazole, Acifex. So on this slide, you'll see the same chart that I had for the H2RAs with respect to those three factors that I wanted you to focus on, so cost, adverse effects, and route of administration. So starting at the bottom, again, we have both IV and PO versions of these drugs available, so again, that's a good thing. As far as the adverse effects, there are more here for PPIs. A lot of these are considered as warnings, not as much adverse effects, but I listed them anyway. So again, we've got the drug-drug interactions, changes in electrolyte status, increased infection risk, specifically nosocomial pneumonia, acute interstitial nephritis, bone fractures, that's a new one, deficiency of vitamin B12, and then C. diff I highlighted. So C. diff is one that's huge. When I spent time at Florida Hospital, this was their biggest reason for choosing H2RAs over PPIs. I did find some literature that said that there was no clinically significant difference between the incidence of C. diff with H2RA patients versus PPI patients. But again, I also found some that did find a difference. So none of it's really convincing at this point. On the left side, you'll see my point that we do need adequately powered studies that compare PPIs to H2RAs with regards to not only efficacy in preventing bleeds, but also their adverse event and side effect profile. Because this C. diff thing, there's conflicting data, and we really need to know where do we come down on this. So, and then talking about cost, pantoprazole IV costs $4 per day per treatment versus only 98 cents for IV famotidine. So clearly, in that situation, the H2RA is significantly less cost. On this slide, I've included a timeline that I got for stress ulcer prophylaxis. So basically, it starts back in the 1970s. You can see the incidence of clinically significant bleeds was between 5 and 33%. That's a big range, but it was 1970, so who knows about data quality back then. But we also had the approval in 77 of H2RA, cimetidine. As you continue on through the 80s, more H2RA agents were approved at that time, ranitidine and famotidine, and so that was sort of the era of the H2RAs. Those were the agents that we had available for stress ulcer prophylaxis, and as you can see from 84 to 94, the incidence went down kind of 0.1%, ranging up to 39%. So again, we do have a wide gap. And that gap could even have shown an increase in the incidence of stress ulcer prophylaxis, but just take those values for what they are, and they may or may not have been, what we think they were. It might not have been the result of the H2RAs. But then 1995 rolled around, and we had lansoprazole approved on the market. Then continue on to omeprazole and pantoprazole, and then esomeprazole back in 2001. And so now in 2010, we've seen the incidence of clinically significant bleeds decrease down to 5% or less. So knowing that both of these agents are used commonly, we really need data that shows which agents have been used and which ones have been most effective, because that data is not really strong at this point. I can tell you that if you go to Florida Hospital, where I was, they tried to use famotidine as much as possible over Prophylaxis because of the side effect profile that the PPI does have. Now, go over to Tampa General, and the pharmacist there will tell you the complete opposite. PPIs are more effective, so that's why we use them. So it's just, right now, it's pretty institution specific. And when I looked at guidelines, the newest ones are from the 90s, and right now I went onto the ASHP website, and they are working on guidelines that are supposed to be released this year. So I'm anxiously awaiting to see what those guidelines will say, and hopefully they will give some clarity to which agent would be superior. So as if I haven't confused you enough already about which class of medications would be most appropriate, now we're going to really dig into the literature. I'll talk about some of the studies that I found, and I just want to present you with as much information as I can, because since we don't have clear-cut answers, I just want to present to you the information that I found, and really at this point it's your professional judgment about which agent you would select. Some people are going to choose PPIs, and some people are going to choose H2RAs. And so we'll start by talking about a study by Levi. It compared IV ranitidine, and they did a 50 milligram bolus plus a 50 milligram IV infusion every 8 hours, and that was in comparison to oral omeprazole, 40 milligrams, and they either gave that by mouth or through an NG tube every day. Now you can already see the limitations that could arise from having these two treatment groups. You're comparing not only different agents, but different routes of administration. So take this for what it's worth. The ranitidine had more bleeds significantly. This was huge. The ranitidine group had 31% versus 6% in the omeprazole group. And they said that the nosocomial pneumonia that developed was equal between the two groups. Now, when you really looked at the patient populations, the people who they put on the IV ranitidine had way more risk factors. And as we know, the risk factors increase. As you have more risk factors, your incidence of bleeding is going to go up. So if you had a whole bunch of patients in the omeprazole group with only one risk factor, well, okay, they were already less likely to get a bleed, as opposed to if you had patients in the ranitidine group, which we did have, that had more risk factors. Now they're already at an increased risk of bleeding. So we can't really say, was it the choice of agent? Was it the route? We can't really draw those conclusions from this study. So fast forward to this next study by Phillips, where we compared an omeprazole suspension versus that was given via NG tube versus ranitidine continuous IV infusion. So we saw that the ranitidine in this case was more expensive. In this specific trial, it was $20.32 for the ranitidine versus $12.85 for the omeprazole. This study showed the pneumonia development was increased in the omeprazole group at 18% versus 16% for the ranitidine, and the clinically significant bleeding events were again 16% for the ranitidine group and 3% for the omeprazole group. So this study also went to the PPIs. as far as both cost and bleeding events, and saying that the pneumonia risk was just equal. So certainly when you're looking at this data, you're thinking, oh, PPIs are definitely better. So this study was pretty much in line with what the Levi study said as well. So after having looked at those first two studies and feeling like I had a pretty good idea that PPIs were going to win this argument, I then found this meta-analysis. And this meta-analysis included the Phillips and the Levi study, as well as several other studies. And when you look at this specific table, which shows you the overall effect, you'll notice that the little diamond is touching the line. So even though it looks like it's probably leaning towards the PPI side, it's touching the line, not significant. So we cannot draw that conclusion that PPIs are significant with regard to decreasing the incidence of clinically significant bleeding because the data is just not there at this point. In the same meta-analysis, they also looked at adverse effects. So they looked at the top in the section A, they looked at pneumonia, and again, we have no significant difference between favoring the H2RAs versus favoring the PPIs. So then they also looked at intensive care unit mortality. Again, there's just no difference found between these two agents. So with the data that we have available right now, we are not showing that one agent is any better than the other. We're forced to look at other things, certain cherry picking of adverse events or whatever basically the hospital can get that's cheaper, or if we're limited by the route of administration of the medication. So this meta-analysis basically just reinforced my confusion about which agent would be better at this point. So after explaining the source of my confusion, I was reading through the literature and I found this paragraph and it really spoke to me. So I'm going to go ahead and read it to you verbatim. So based on current data, there seemed to be no substantial difference in the frequency of upper GI bleeding and pneumonia among oral and IV PPIs and IV H2RAs. If the decision is made to suppress gastric acid secretion, then patients should be treated based on their individual risk factors for stress ulcer. We suggest that health professionals should make treatment decisions that also account for convenience of drug administration, potential drug-drug interaction, and cost. Further studies should emphasize patient risk stratification and explore the optimal regimen of stress ulcer bleeding prevention in terms of drug, dosage, mode of administration, timing, and duration among patients with different risk levels. So in a nutshell, what all of this is saying is that it just depends. It depends on the patient. It's as long as you can defend your decision for why you're choosing a particular agent, then neither one would really be superior to the other. So it's really your choice at this point. I'm hoping that when the ASHP guidelines come out that they can shed some light on, which agent is better for which specific patient population. We learned in the sepsis guidelines that they specifically call for PPIs. So hopefully the ASHP guidelines can give us something like that so we can see, regardless of what our patient comes into the ICU with, we can say, oh, they fit more in this category, so we're going to choose this agent for reason X, Y, Z. I thought that this chart was really interesting. I pulled it from the ASHP guidelines from 1999. And as you can see, it includes mostly H2RAs. It tells you how to dose them for people with normal renal function versus reduced renal function. And the only PPI that they included on there was omeprazole, and they also said that there is no dose adjustment necessary. So in the upcoming guidelines, I expect that there will be many more PPIs on the literature that they publish. And also, maybe cimetidine will fall out of favor. But I just thought that this was a really good tool so that you can pull whenever you're trying to dose these medications, and you can see how they're given for prophylaxis dosing with or without the presence of reduced renal function. This is just a table of options of the agents that are available in the histamine 2 receptor antagonist class. So as you can see, you'll see both name, brand, and generic, how the drug comes PO, if it's available both IV and PO, if patients can get it over the counter, and also it lists drug interactions. So I think that that's really important, something that you can just either commit to memory or have it in sort of a, a pocket folder somewhere so that you can reference it really quickly when you're on rotations, because it will become important. Like, we'll be able to switch, if the patient becomes NPO, can we switch it? And depending on which medications are on, will it interact? So this is a really great reference. This is another table that just includes the PPIs. Again, it lists their PO strengths, if it comes available as IV and PO, if patients can get it over the counter, and this will actually need to be updated because it says that esomeprazole is not available OTC, which, as we know, is incorrect. And also notice that it does not list the drug-drug interactions, which is an interesting point because that is important in the proton pump inhibitor class. So at this point, I hope that I have convinced you about the complexity of stress ulcers, and I hope that you can appreciate the importance of prophylaxing against them in the ICU population, especially with those risk factors that we went over. So again, there's the controversy that exists among the various treatment approaches. This is basically the war between H2 blockers and PPIs. Hopefully this year ASHP can give us a little clarity on that, but we'll have to see based on constantly evolving data. Also, as far as choosing the appropriate prophylactic regimen for a given patient case and being able to defend that, you're not really going to be wrong unless you choose an agent that is just off the wall. So it's not that you either have to choose a PPI or an H2RA blocker or you'll be wrong. As long as you can say why that was most appropriate for that patient in particular, then you're fine. Again, with something like sepsis where they've told us that PPI is the preferred regimen, that's something, where we would choose one class over the other. But in general, there's no consensus over one being better than the other. That's very hospital specific. And then advocating for patients with regard to being discharged from the ICU, the story here is that they should not be discharged on stress ulcer prophylaxis medication. If they're using the medication for treatment of some other thing, like GERD or whatever the case may be, then that's fine for them to have it, but it's inappropriate for them to leave with specifically stress ulcer prophylaxis. So that's the time when we want to discontinue the medication. A lot of times we're seeing, again, the overuse of these medications, so we're basically just adding side effects and adverse events to these patients unnecessarily when they don't need them anymore. So as soon as you can eliminate the risk factors, which are the reason why you're putting them on the stress ulcer prophylaxis, once those risk factors are gone, the medication should go away as well. This is a list of the references that I used. I mostly went from the Coda Kimball textbook. I sort of went through the ASHP guidelines, but again, I know that information is outdated, so I kind of took it for what it was, and I can't wait for the update because I'll certainly be reading it if they bring it out this year. And the rest of them were pretty much the studies. If you have any questions, please don't hesitate to ask. I'm more than willing to print out the full versions of these studies of the primary literature so that we can go deeper into it if you have any questions. They were an interesting read, and I will say I was kind of disappointed when I got to the end and saw, oh, there's no difference, oh, there's no difference. Or from one study I would see, yes, histamine receptor blockers are certainly preferred. And then the next study I read, it says PPIs are definitely preferred. So again, there's a conflict there. I'm more than happy to have this conversation with anybody, and I really look forward to our game tomorrow. I think it's going to be a lot of fun.